Okay, well, I think I'll start doing the introduction, and by the time I've blathered on for a minute or two, maybe everybody will be here, and then we'll get started. So welcome, and thanks for joining us. This is Snapshot Session 2. My name is Robin. I'm the moderator for the session. Before I introduce our speakers, and we start the session, just a couple of small reminders. You can increase the size of the slide presentation by right-clicking on the presentation image, selecting Picture in Picture, and resizing the pop-out window. Okay. This is a snapshot session, meaning we have 3 presentations, all of them on the theme of care in different settings. After each presentation, I will spend just a minute or two on any questions that have come up in the chat, and then we'll move on to the next session. After the presentations, we'll have a discussion period with all of the presenters, and at that time, you'll also be able to ask questions. So when we get to that point, you can raise your hand and then use your microphone and ask your question. So let's start. So our first presenters will be speaking about care connections in the emergency department. And our 2 presenters are Dan Brunet and Laura Hill. Dan Brunet is a bilingual registered nurse on the Addictions Medicine Consult Service at Health Sciences North. Since graduating in 2000 from Cambrian College, Dan has worked in many nursing roles in both Sudbury and Ottawa, including medicine, surgery, critical care, and most recently, emergency medicine and emergency department outreach services. That's bringing the ED to long-term care homes at Health Sciences North in Sudbury. Dan joined AMCS team in 2020 during its first year. He is an excellent role model and mentor for those around him, and his interactions and care for the patients referred to AMCS are impactful. In his spare time, Dan enjoys spending time outdoors with his family, woodworking, and exercising. So clearly, Dan is a much more active person than I am, because my interests are much more sedentary. Laura Hill is a nurse practitioner on the Addictions Medicine Consult Service at Health Sciences North. Laura obtained her Bachelor of Science from McMaster University, Masters of Nursing from York University, and her Nurse Practitioner Adult from University of Toronto. Nursing roles for Laura in Sudbury and Moose Factory have included medicine, obstetrics, emergency department, geriatrics, and most recently, the AMCS. She has published on topics such as advanced care planning, antipsychotics in long-term care, and is currently researching multiple quality improvement initiatives for the AMCS. In her spare time, Laura enjoys camping, walking her 3 dogs, volunteering on various community boards, and spending quality time with her family. So over to you, Dan and Laura.
Laura, I'm not hearing you. I don't know if others are.
No, I was just coming on to say that we can't hear you.
There we go. Can you hear? Is that better?
Yep.
Oh my gosh, I'm so sorry, guys. So we had no disclosures, other than that we work at the hospital, and I work part-time at the university. And we are using quantitative data to try to mitigate any bias that we would have, since we're talking about our own project that we're doing for quality improvement. So we tried our best to keep it quantitative and not use any of the qualitative yet, so that it's the data talking and not us. So basically what ended up happening is we had the starting point where we had finally got our full team developed. So we have our full-time RN, NP, and a 0.3 physician model. And our focused area was that we knew we needed to do a bit better in the emergency department and helping the patients when they came in through the front doors. We didn't know where we needed to help, though. So we tried to figure out what we needed to measure to figure out what we even needed to fix. So we started with this really broad net that we cast, looking at all of the charts. And we modeled it after the Health Quality Ontario Emergency Department return visit, where they look at the 30-day returns for patients with 3 sentinel diagnoses. So we included our data analyst team. They were able to pull some data and lists for us. We were able to look at the emergency charts as in this retrospective review, because they're all scanned online for us. We partnered with Laurentian University, Dr. Heel, who is one of my mentors there, and she helped us with the statistical analyses. And we also got this research ethics board approved. We were trying to find one or two areas to start to work on. We figured we'd be looking at doing some sort of warm handover process between emerge and withdrawal management, or AMCS and withdrawal management, because we do have a withdrawal management that's off-site, but still part of the hospital programs. And we thought maybe we'd have to try to decrease our time to seeing patients in the emergency department as areas that we could improve on our own. When I did the chart audit, I looked at 753 emergency charts from the past fiscal year. What we ended up finding was a bit surprising, actually, is that we only got referrals for 55 charts out of that 753. So essentially, we had a 90% area of complete blindness. We found also, not surprisingly knowing the statistics, but surprisingly based on our team's work, where we mostly see opioids and stimulant referrals in the hospital walls, we are actually seeing more alcohol presentation as the main presentation for emergency department. And so I'm going to hand it over to Dan to talk a little bit about how he's been working with the emergency department to increase our care connections.
Hello, everyone. So essentially, it's really just time and effort every day, making our presence known in the department, showing up, being visible, answering any questions that the emergency staff might have, making connections with essentially, I call them the gatekeepers, so the registration clerks in the emergency department, the triage nurses on that shift, and repeating that every day because of the turnover of staff, and essentially just answering any questions and them seeing what we can offer through our visibility by what we do. It also creates an awareness and a thought process. Oh yeah, when there's a CWA, I got to put in for AMCS. So on and so forth, and then connecting with the physicians and also engaging to try and encourage, even putting in for the referrals when we're not present. We're at this point in time, we're an 8 to 4 service, weekends off because of funding. However, we still are trying to get these referrals put in 24/7, even on the weekends, to show the need and to also keep it relevant even when we're not present, just to make sure that we're still in their mindset when they think about substance use and addictions.
Yeah, and so for the first quarter, we concentrated just our efforts towards alcohol use disorder in how we were doing follow-ups, but it didn't change how we were messaging to the emergency department. We were collecting how many contacts we made. And so Dan talked about going every day. And so we had aimed for about a 20% face-to-face engagement rate with all the nurses, physicians, and ward clerks that would be on shift at that time. So we made a list and figured out how many would be in each zone. And we just cycle between each zone, talking to those people, do a quick tick sheet. And our quality improvement lead keeps those data for us. And this is what it looked like. So we had some dips and some valleys over the summer vacation time, just because engagement was a lot harder. And we were running a lot more just individually trying to see all the patients in the hospital, and definitely weren't able to keep up with all the engagement work in the hospital. But it really was a low workload, high impact for us. When there's 2 of us on, it's not hard to go down to the emerge and have those chats with people. We started measuring our success, and we're in that phase of the cycle right now. So we're looking to see if we can get some increased referral volumes, decreased time to us actually connecting with the patients. So from the time that they triage to the time that we see, we'd like to see that number reduced. We want to see increased connections with outpatient teams like our withdrawal management services, but also our rapid access clinic and our outpatient addiction and gambling services, and an increased use of appropriate medications. So that comes into play a lot with our people coming in who have been using fentanyl or for alcohol. And if we can get them on the right medications and be more successful in helping them at the emerge, we're hoping we'll see better uptake and continuance in the community for these patients. We are also doing after-hour callbacks. We want to make sure that we're still impactful. So if people are putting in referrals when we're not there, I'm making the effort to call the patients the next day if we have contact information. If we don't have contact information, we already had a process in place where our crisis outreach workers who are on the ground downtown, they walk around every day in our core, and they know most of these patients. And I'll just remind them that we don't have a contact information, and they'll pick them off their list and go and check in and make sure they're doing okay. Q1 was really slow. We only had 5 referrals. And so in Q2, we opened it up to all referrals, not just alcohol. And I've actually made a lot of connections with people who are using opioid use disorder. We had first targeted the alcohol use disorder because 80% of those folks were housed. But then we realized that we had a lot more room to expand based on our use. We are seeing growth over the quarter. So when we looked at it, the original visits just have gone up in number to our emergency department. But we're also seeing a big increase in the percentage in volume that we're seeing from the emergency department. And that's, again, what we're trying to measure is that the emerge physicians, emerge nurses, and ward clerks are putting those referrals in at the beginning of the person's stay in the emergency department, rather than being only getting admission referrals for people who are staying in for psychomedical needs. We'd like to see them right from the start. And sometimes we can divert them from the waiting room right to the withdrawal management. We know that we're not doing everything we could because we're not there every day, all day, and we're not there at weekends and evenings, but we're doing the best that we can with the age of 4. And we're hoping that if our stats show that we're needed, we can try to get some more funding. We're flexible in our hours of operation, and we're working on the data to try to sort of work on that. And we're also taking some of the subjective information the ED staff are giving us to try to make our service more accessible to them. So we already have a cell phone with an extension number that they can call. They can send us an email, they can put in a referral in the computer, and we made the computer referral even easier. It used to have about 5 questions they have to answer. Now we just want them to basically put in the person's name and the referral, and then they can enter it. They don't have to put any more information, because the ward clerks brought up that they don't always know what the person's on and they don't know what the person needs, but they know that the person has a substance use disorder. That's it. That's how we're starting to make our care connections in the emergency department. And it's going really well, actually.
Great. Thanks, Laura and Dan. I don't see anything in the chat, so I'll just put in one quick comment. When we started the Toronto Community Addiction Team, I think your thing about talking to people at the start, we had one hospital that we had particular challenges with. And what we realized was that it was the referral to the people who could refer to us didn't happen until the doctor was done with the person.
Right.
So the referral was made at discharge, which meant, of course, we couldn't get to the emerge room to see people before they were gone, even though we had staff ready to go. And so we had to work on that. And then on the alcohol, we had a specific issue around the doctors not making referrals and not suggesting anybody else make referrals for the drinkers, because they didn't really do much with the drinkers, because their experience was the drinkers would come, the guys who were drinking heavily would come in, the doctor would check to make sure they were okay. And then the nurses came to tell us, well, no, you know what, we're doing all the work with these folks.
Yeah.
So the doctors don't even really notice them.
Yep.
And so if you want referrals, you got to make sure the hospital lets us make the referrals, because we're the ones doing all the work with these people.
Yeah, that's
and
exactly.
We're the ones who care that they get somewhere else, because for the doctors it's just, oh yeah, he's okay, and move on, right? So
just let him sleep in the hallway for 8 hours.
Yeah, for sure. Exactly.
Yeah. So we were lucky that way, because we're both emerge nurses at this hospital in our past lives at this hospital. So we kind of had an inside scoop on where we could hopefully get some better leverage.
Sure. One other comment in the chat. So Jennifer was interested in identifying ward clerks as a first point of contact. How early can the referral or connection be made? Who is most impactful to connect with?
Yeah, so the ward clerks, the way our emerge works, I don't know how it's changed since. Still the same, but it's different than other places where they see the ward clerk first to open up a file, then they go to see the triage, then they go back to the ward clerk. So nothing can get put in the computer until they see the ward clerk the second time, because they don't have a file opened up for anyone to type in orders. But our ward clerks are actually really jazzed about putting in referrals. They feel it seemed for them to be a really empowering situation where all of a sudden they can actually make a difference. They know these people, they see them frequently, and they have felt really comfortable calling us. So they call us on our cell phone and just let us know that they have it. They're really pumped when they make one and they want to like chat about the fact that they remembered. And
at this point, there's really no criteria other than suspicion or a thought, and it's just a blanket referral, and then it's up to us to go in and
get consent
and discreetly investigate and see what we're dealing with. And it's either this is a great referral and a connection's made, or it's great try, but we couldn't find anything, or they weren't interested in anything. But the volume isn't there yet, so we can afford to make these blanket referrals at this point because we have the capacity at this point from the amount of referrals we're getting.
That's a really interesting area. I know when I worked in primary care, the medical clerks often knew stuff that nobody else knew about the patients, right? So
for
it's
sure.
really interesting that you've been able to.
And the way it's set up, they see the waiting room, so they'll see someone slouched over, assumingly passed out or under the influence, and or vomiting, or so on and so forth. And they're an untapped resource from my point of view.
Great. Okay, so we'll move on to the second presentation. Thanks again, Laura and Dan. So next up, we have Monica Forrester and Kavita Maharaj. So if they could join on the stage, that'd be great. So Monica Forrester is the founder of Trans Pride Toronto, and now works at Street Health Toronto, a nonprofit focused on improving the health and well-being of homeless and underhoused people, right down the street from where my office is. So big fan of Street Health. So she formerly worked at the 519 Center, where she contributed to trans programming, promoting awareness and visibility of transgender people. She has worked with various organizations focused on mental health, housing, addictions, sex worker advocacy, and mentorship. In 2023, Monica ran for Toronto Mayor on a platform prioritizing healthcare, housing, and infrastructure. Kavita Maharaj was born in Trinidad. She migrated to Canada in 2003 at the age of 16 and became a substance user soon after due to trauma experienced in childhood. Kavita has worked very hard on herself and has been in recovery for the past 3 years. She gained employment as a peer worker at PSAN, Prisoners with AIDS HIV Support Action Network, in August 2021. She also has worked at Ernestine's Women's Shelter as a primary and mental health harm reduction counselor. Currently, she is a harm reduction and outreach program coordinator at PSAN. She is also a collaborator with the systems mapping research team for the decriminalization of drug possession for personal use. She continues to support marginalized communities using her lived experience as a vital tool. So over to Monica and Kavita.
Good afternoon, everyone. Can you guys hear us? Hopefully. Okay. Robin, could you hear us? Okay, great. So welcome, everyone. I guess I'm Monica.
I'm Kavita.
And today we're going to talk a bit about some of the diverse communities that we're working with. And, over COVID and there was a lot of shutdowns of many different services. Street Health is known for their nursing services here. So we have a lot of underhoused, marginalized, racialized people that access their health care here for just basic wound care, for diabetes, for blood pressure, for even to get prescriptions if they need it for antibiotics and so forth. So through all that kind of interaction and through the drop-ins that I coordinate, there was a lot of discussion around, a lot of people had discussions around how they were treated when they accessed hospitals or spaces that worked around healthcare. So we thought a better time than ever was to, create a steering committee with the different communities that we work with and ask them, what are some of the things that you're experiencing when accessing healthcare? What are some of those barriers? And what are some of the things you would like healthcare providers to know and how to best support people when they access their services? So we We created a tip sheet. So the process is that the steering committee was made up of different community members. So the trans and two-spirited community, the indigenous community, the Black, African, Caribbean communities. And these are the populations we see most of. So we gathered all that information from them. Then we brought it back to the community. So we ran a couple of different drop-ins at Street Health. We brought it back to them for that approval, well, basically that approval, and to add more into the context of this tip sheet that we're putting together. And then, and here we are today. So we're presenting it, and hopefully, what our main goal is to disseminate this information to healthcare providers around the city, hospitals, clinics, community care centers, so people get a better idea of how to best support people in those different communities, maybe working on different policies that are supporting people through a non-judgmental approach. And so we're so glad to be here for the Meta conference to kind of run through some of the stuff that our community has, sorry, our community has communicated to us around services and the treatment of their own personal experiences, and how healthcare providers can best support them. So I think you guys have the slideshow, and then is someone doing that?
Sorry, I'll get it. 1 second.
Okay, no problem. Excuse me. So you're going to start. So as they're getting that together, so Street Health not only has a nursing team here, we have an OPS. We also run various drop-ins, one for women, trans folks, and non-binary folks. We have another drop-in for anyone. We also have a harm reduction team that does outreach. We do community care, where they go around and pick up used syringes. We have case managers that work directly with community. We have an ID clinic so people that need to get their ID, they can get it here for free. So there's a lot of wealth of services that Street Health provides. So here we go.
Okay. So the tip sheet that we created is caring for populations with complex health and social needs. And like Monica said, this was created by community members that are marginalized or have substance use in their life. So people who use drugs often experience stigma and discrimination when accessing healthcare services. Once drug use intersects with homelessness and or diverse gender identities such as transgendered or non-conforming identities and or diverse racialized communities, the stigma and discrimination is layered and intensified. These tips are intended to inform healthcare providers of how some of the experiences people have endured and to provide practical solutions that can help to resolve the cycle of stigma and discrimination that create negative health outcomes.
So barriers to service for racialized people. Racialized people describe the marginalization that directed at people due to their race. And these are some of the things that we've heard. I've been talked down to by healthcare providers. I've experienced barriers because English is not my first language. I don't see people in healthcare roles who look like me. Healthcare providers don't have the knowledge on health concerns that affect different races. Healthcare providers will assume I'm on meds seeking or dismiss genuine health concerns. I've been sexualized by healthcare providers. I won't disclose everything that happens to me because they discriminate against me. If I voice my concerns, I get labeled. So we see a lot of these things, especially we work with the large sex work communities. So when they come into the healthcare providers, they'll be like, oh, you need to get tested. They think that they're at high risk groups. It's like, there's a lot of myths when we look at different groups of people that, just because someone does sex work, and sees multiple people in their work, these assumptions that they're at higher risk of HIV and STI infections, but it's just that the language and how they engage in those conversations, where they're demanding that they get HIV tests, STI tests, and even when they're not even going in for those things, because they've disclosed that they were sex workers, they're often subjected to these kind of protocols. So we'll go on to the next slide. Barriers to service for Indigenous people. Hospital staff hide hand sanitizer, assuming I would drink it. Hospital staff assuming I'm intoxicated. Hospital security acting in an aggressive manner. Healthcare providers assuming I'm on meds, seeking other kinds of medication. My status card wasn't recognized as valid ID. Healthcare providers assume I was homeless, and not being allowed to smudge in hospital. So these are just some of the things that we got from community when they access certain healthcare facilities or hospitals. Things are changing. We're not saying there are some hospitals that have actually adapted to allowing smudging in their hospitals. But these are just some of the common assumptions that a lot of health providers assume when Indigenous people come into their emergencies or into their community health centers. So barriers to service for two-spirit, transgender, and non-conforming people. Healthcare providers assuming or ignoring my identity. Healthcare providers not asking for preferred pronouns. Healthcare providers using my dead name as a given name that no longer has any use or meaning. Limited number of healthcare providers working with trans, non-binary, and two-spirited people. Medicine has rigid perspectives on how a male patient with ovarian cancer is understood. Healthcare providers confuse identity and sexual orientation. So these are, once again, a lot of common things that a lot of two-spirited and trans and non-conforming people experience. Once again, the people are always assuming that self-identified women should look a certain way, just like self-identified men. You know what I mean? So they're making these assumptions, always mistaking their pronouns from he to her or her to he. And I've seen this actually with that two-spirited folk that clearly wasn't looking male or female, and that even had it on their charts, their dead name, but also in brackets their chosen name, and they were still using their dead name. So these things happen very frequently. So, it happens, but at the same time, it's something that healthcare providers really need to really be addressing and creating maybe, working with some trans-led agencies like Trans Pride Toronto or places that actually do Trans 101 workshops, because we all know that a lot of health services, their staff are, the turnovers all the time are consistent, right? And sometimes people don't know how to best support people, you know what I mean? So it's always good to have a lot of this stuff too in policy when it comes to assuming or all those different things. Okay, go ahead. Do you want to do this one?
Go ahead.
How to better support Indigenous people in healthcare. Learn language that isn't centered in colonial and binary understandings. Create an organizational culture that is informed. Provide a diverse healthcare team. Have Indigenous elders available. Have other roles for Indigenous people such as patients, advocates, or patient navigators. Have elders involved in advisory committees, boards, and appoint traditional knowledge keepers to key organizational positions. And develop campaigns to welcome Indigenous people. So these are just some of the stuff that a lot of proactive, things that a lot of healthcare providers could do to make these spaces more inclusive, more welcoming through a non-judgmental approach, and yeah.
And this feedback is coming from Indigenous community members.
Yeah.
Yeah.
Consideration. Ensure non-punitive approaches for missed upship. Oh, sure. Okay. Oh, I know there are two different levels. Sorry.
Yeah.
Ensure non-punitive approach for missed appointments or late arrivals. people are in survival mode and may not have the transit fare to get to their appointment time, may conflict with food banks, meal program times, life can be chaotic, etc. Avoid expensive treatments that patients may not be able to afford. Be transparent about all possible solutions to find what works for them. If possible, provide a mobile service and community to expand reach and make attendance easier. So as you know, a lot of especially there's a lot we're dealing with a homeless crisis, a lot of people in encampments, and maybe some of the people that we here at Street Health might redirect to maybe some of your healthcare or Women's College or Toronto Western. These are some of the things to really recognize. I think when you're doing your intake, it's really get a sense of, what are some of the issues, not only the health issues, but what are some of the ways that you can best support people that might be homeless? You know what I mean? Working around a good time, around appointments, around treatment. If someone's got no health benefits. How does this work in a ways to be able to afford treatment? So I think it's great that we have better conversations with communities that are more marginalized and living in precarious housing and stuff like that. So be aware that mixed race patients may have the needs that aren't apparent. Don't assume people's identities. Ask them what their preferred pronouns and name is. Take a holistic approach. Work with patients to understand how to treat them. They know their situation best and have the power to better themselves. Respect the patient's boundaries. Vulnerable populations may carry a lot of trauma and may keep to themselves to stay safe. Always let them know what you're doing and ask for consent. Be curious about what's behind a behavior versus judging it. Building trusted relationships and the responsibility of the provider and will garner much more meaningful information. If someone isn't actively reporting the substance use, they likely had negative experience in trying to protect themselves. A narrative approach versus a Q&A style will help to build the trust and gather more complex history. So just to kind of tail back to, yes, we know at Street Health, people are coming in with different situations. I'm not saying, people should respect people, but we gotta really be understanding of, people that are maybe not have eaten that day. They might have been policed out of their encampment. They might be using drugs, or just maybe having a shitty day, right? So we have to, make sure, that we understand some of those complex issues, but also, there's also policy and procedure on how we can best address those things. And I think it's having a conversation, working through a restorative justice approach where we're not barring people, or because if someone's coming to your health services, they're obviously coming there because they need some sort of health service, right?
Absolutely.
So it's kind of working for a non-judgmental approach, restorative justice approach, right? And really, really understanding when you're dealing with homeless populations or people that use drugs. Most often some of their behaviors are due to their social locations or just the situation of that day. Consideration. Do you want to do that one?
Sure. Make waiting rooms friendly and welcoming. Ensure that all staff, which are receptionists, technicians, nurses, doctors, are skilled in working with folks who are homeless and or using substances. Minimize the level of stimulation in waiting areas as best as you can. Consider lighting, noise levels, proximity of seats, etc. Consider hiring a community member to be a greeter. Have signs to let people know that Narcan is available. Have a welcoming statement and list what expectations patients can have. For example, being treated with respect, being listened to, and not being judged. Have signs in waiting rooms that demonstrate the provider's commitment to diversity. Display trans and two-spirit pride colors, posters, and information. Display informational posters listing pronouns and identities. Just creating a comfortable environment that would make someone want to access the services and want to stay there and wait to be seen, because sometimes it can be a long wait as well in the hospital, especially when someone's unwell, if they've been using substances or if they're unhoused, right?
And I think when we're working, because there is a process when we go into the hospital. So first, a lot of people, especially in emergency, are met by security, then they're met by the intake, and then they're met by the waiting room. So I think it's really important that security is part of that training piece when people are accessing. So they're understanding the diversity of people that are coming into your space, that they, and some of those experiences that people are having. So they're not misgendering people. They're not being aggressive because someone has, So I think it has to start from all different levels within the healthcare system, that everyone are on the same page. We understand these places can be hectic. We have it here.
Yeah.
We understand, there's a lot, there's so much overwhelming in a lot of the healthcare services, you know what I mean? But at the same time, we also got to be mindful of some of the populations that we're working with and how we can best make their experience a good experience. And that's about it.
Also have the goal of Always have the goal of wanting to make the person come back. Provide as much help as you can in one visit. Ensure non-punitive approaches for missed appointments or late arrivals.
What we did then?
Go ahead.
Building strong relationships. Recognize the patient as the expert of their situation. Consider that this may have taken everything this person in front of you had to make an appointment. Engage senior management in the organizational policy of cultural competency, cultural safety training, and request that a standard of care is set for your setting. All staff should be trained in trauma-informed care, harm reduction philosophy, culturally and safety, anti-oppression practice, include security, reception, and admin staff. Educate staff on the power and privilege and the responsibilities that comes with that, including the responsibility to advocate for their clients and respond when they hear discrimination in the workplace. Inform people of their rights inside the healthcare center and try to see patients and clients as community members, as a community you belong to.
You may not be able to assess every patient. If the situation is too much to handle, refer them to someone who can handle the situation or bring in an understanding mediator. And be understanding that patient maybe not be in a good place emotionally, but still need care.
Summary of tips. Be fluid in the needs of folks who are homeless or using substances. Know community resources. Do they have a support worker? And if so, can this person assist with a care plan and appointments? Understand poverty. Be competent in substance use and dependencies, harm reduction, mental health concerns, head injuries, FACD, and developmental challenges and trauma. Understand diversity, for example, how racism affects health and outcomes. This work really requires expertise and commitments to be done well. Be kind, caring, compassionate. Remember to be non-judgmental, non-discriminatory. And this is our lovely team, some of our community members and helpers and staff at Street Health. I think that's it.
Yeah.
Oh, how do we...
So creating this health tip sheet was super important to me because, as you guys heard in my biography, I was a substance user for many years, and accessing healthcare was a huge barrier for me. I was constantly dismissed. I was treated poorly. I could see the difference now because now I'm in sobriety. I could see just the difference in how I'm being received in the healthcare. So I just, I really wanted to add to this tip sheet and engage other community members that have been hearing these experiences from. And I think that everyone deserves care regardless of their situation. Someone could be a substance user and having a heart attack, which may have nothing to do with the substance, and they deserve to be seen. Healthcare is for everyone.
Great. Thank you, Monica and Kavita. There aren't any questions in the chat, but I used to run a primary care team. And so I thought we had a lot of patients. We had served a lot of folks with mental health and substance use. And we had a lot of our patients did not make it to appointments very well. And one of the things we ended up doing that I think was really helpful was having a drop-in clinic that with our nurse practitioner that was, only for patients of the clinic. And so folks who were struggling with appointments we would always make sure they were aware of that clinic, and sometimes some of those folks would decide not to make appointments,
Mhm.
just to show up for the drop-in clinic, right? Because I think for them it was easier to go, okay, Friday afternoon from 1 to 4, I
Mhm.
can make it somewhere in there,
Mhm.
right?
No,
An appointment. And I don't know if that's something that how common that is in primary care, or if not. I think at the time we did it, it wasn't. And I just wondered what you thought about like some of those kinds of approaches to help
all
people.
that approach is great because that's how we do it here at Street House. We do have a nurses on 5 days a week, but we have like different set times for like drop-in settings for like we have gender affirming care on a certain day during this like it's usually the whole day, right? So it allows people that like you said that can't make appointments because maybe they don't know where they're going to be at tomorrow or something, that they know a time frame. So that's great that you guys have set up that kind of strategy that
Mhm.
actually works for people.
Yeah, I feel like services like that should be implemented across the board, you know?
Yeah, I think
Yeah,
especially for us with
totally.
the folks with mental health, what we found was a lot of our clients would realize on a Friday afternoon that they were running out of medications.
Mhm.
They need a prescription renewal, and they turn up Friday at 4 o'clock for their prescription renewal. And having the drop-in clinic meant that people didn't have to go without medications over the weekend.
Mhm.
Right? So, thank you very much again, Monica and Kavita.
No, thank you
Thanks for having
guys.
us.
And so we'll move on to our third set of presenters. Um, so our final presentation is about elective admission for management of alcohol withdrawal in a short stay medicine unit in Toronto, opportunities and outcome. So our two presenters are Marc Dagher and Mariangela Castro Arteaga. And I apologize if my pronunciations of names are not perfect, but I did my best. So Marc Dagher completed his medical training, residency in family medicine, and enhanced medical skills training in addiction medicine at the University of Toronto. He is currently working as an addiction medicine physician in the academic and community settings. The research project presented at this conference was carried out or is being carried out as part of his work in the substance use service at Women's College Hospital. And Mariangela Castro Arteaga is a clinician who graduated from medical school at Universidad Libre Cali in Colombia and completed her master's degree in community health at the Dalla Lana School of Public Health at the University of Toronto. Currently, she is supporting research in different areas of Indigenous health in Canada and the social determinants of health of vulnerable populations in Latin America. Her career centers around the intersection of medicine, public health, and social sciences to promote better health outcomes for those in need. Over to Mariangela and Marc.
Thank you,
Yeah,
Robin.
thank you so much. Yeah, just let me share my screen. Yep.
All right. Thank you, Mariangela. And hi, everyone. And thank you, Robin, for the introduction. So Mariangela and I would like to present this project that we're working on at Women's College Hospital, along with Dr. Jennifer Wyman, Dr. Meldon Kahan, and Susan Hum. And this project looks at the management of alcohol withdrawal in a short stay unit. Next slide, please. We have no conflicts of interest to declare and no financial support to disclose. Next slide, yeah. What we're hoping to accomplish in this presentation is first explaining the rationale for this study and the protocol that we used in our short stay unit for managing alcohol withdrawal. Second, we'd like to describe the patient outcomes from this short stay unit. And last, we will discuss some opportunities for managing alcohol withdrawal in other settings. And before we get started, first, I'd like to just a bit of background about alcohol use. I'm sure this audience is well familiar with the harms and the costs on the economy that can come from alcohol use. But just a bit of a reminder, in a survey done in 2019, about 76% of respondents that were of the age 15 and older reported that they consume alcohol. And what that translates to is shown in this graph here. You see the first bar that relates to the cost of alcohol. It accounts to about 40% of the total cost of substance use in the economy, in the Canadian economy. And if you look at the breakdown, a lot of it is coming from loss of productivity. And after that is, of course, the cost to the healthcare system. but you can see that that's more than any other substance that's shown in this graph. And next slide, yes. And looking at our study, the rationale, why are we looking at alcohol withdrawal in a short stay unit? So first of all, alcohol withdrawal is very important to manage, of course, because we know in many of people that are trying to overcome their alcohol use disorder, whether it is to reduce drastically or to stop drinking altogether, a lot of time the barrier to start is managing the alcohol withdrawal. So looking at ways that can support people getting through that initial phase are very helpful in supporting them in their journey. Now, why are we looking at it in a context of a short stay unit? What we have seen and what we hope that the gap that we're hoping is to bridge is one where a lot of our patients are hoping to connect with community-based services. And we know that a lot of those services don't have the capacity to medically supervise alcohol withdrawal. So we're hoping to bridge that gap by admitting patients to this short stay unit. And lastly, I want to mention, how does this compare to an emergency department visit? Of course, an ED can manage alcohol withdrawal and its complexity. But again, due to the high volumes, high demand, competing priorities in an emergency department, a lot of times it's hard to create that connection with the community and ensure follow-up, as opposed to this short stay unit that is integrated with our service, and we can ensure those services and the follow-up. Now, a bit of overview on that short stay unit. So at Women's College Hospital, we call it the Acute Ambulatory Care Unit, or AACU for short. This is a general medicine unit. Typically, patients are there for 18 to 24 hours. It's staffed by an internist and medical nurses. It is a low acuity unit. So even outside of our context, this unit typically sees patients with general medical issues that are lower acuity than those that might require a full scope hospital. And just for those that don't know Women's College Hospital, we don't have inpatient units similar to other hospitals. We don't have an ICU similar to other hospitals. So that's why the things that we see, we try to keep them at an appropriate acuity. So that leads us to our context here for alcohol withdrawal. Patient selection is very important for us because we want to make sure we select the right patient that would benefit from our services, but also does not exceed the acuity that we can handle. So of course, we want patients that are motivated to change, whether it's to reduce drinking or stop drinking altogether. Patients that need medical supervision for their alcohol withdrawal, and also patients that would not be able to do so at home. So again, this is a step up from home detox, but also not someone that quite requires a full scope or an emergency department visit or a full scope hospital, as I was saying. So that brings me to a bit of an exclusion criteria. So if somebody has a history of requiring ICU for their alcohol withdrawal management, that's not someone that would be appropriate for our service. Someone that in the past had an alcohol withdrawal seizure while being treated for alcohol withdrawal also is someone that we would exclude. And finally, if somebody has a lot of medical comorbidities that are not well managed, again, that's someone that would be a person that might require more care than we can handle. So those patients are excluded. Those appointments are those admissions are pre-arranged. So again, it's planned with the patient at a specific date and time, and we ask them to stop drinking the day before, so we can capture them in that acute alcohol withdrawal phase. And again, this is supervised by a medical staff, nurses, and a physician as well. And next slide, please, Mariangela. I'll tell you about the protocol that we use for supervision. It's a protocol that's familiar to all of you, I'm sure. It's a CEWA-based, symptom-triggered protocol. We, of course, try to use diazepam, but in certain situations, it might be contraindicated, and that's when we use lorazepam. It's given, again, it's symptom-triggered, given for CEWA score of 10 or higher, and it's discontinued once CEWA is negative on 2 consecutive occasions. That's a CEWA score of less than 8, and the patient has minimal symptoms. At discharge, some patients are given some benzos to take home. Those are patients that typically have a few residual symptoms, or they've tried this before and they still had symptoms for a day or two, not quite enough to trigger you know, a COF 10 or higher, but for comfort and just to make it easier for them, we might give them a very short script for diazepam to take home. Everyone leaves with a prescription for an anti-craving medication if they weren't already on it before. And lastly, we make sure they have a follow-up in our clinic. So again, this is a service that's very integrated with our clinic, outpatient clinic. Looking at our study, this is a retrospective study. We reviewed charts and admissions between January 2019 and March 2022. We looked at 92 charts and excluded 19 of them because there were other substances and we wanted to focus on the alcohol withdrawal piece. So that left us with 73 charts to review. And just a quick note, we present everything in diazepam equivalents. We use a conversion of 1.5 milligrams of lorazepam equates 10 milligrams of diazepam. Looking quickly at the spread of our patients over age and sex, we see that we have 55% females, and the spread over age, you see it in the graph. Majority of our patients were between the ages of 30 and 60. And in terms of other characteristics, so the median age, to the next slide, Mariangela, please. Yeah. So the median age is 48. In terms of alcohol use at admission, the median standard drinks per day was 11. And the number of visits pre-admission at our service, at our outpatient addiction medicine service, is 5. And again, that speaks to that integration that we're trying to accomplish between this short stay admission and our outpatient service. So during those visits, our hope is to get to know the patient, get to know their motivation, their goals, plan for services that they might need, and plan this admission accordingly. And our hope is that would ensure a higher rate of success. And the COS score of admission, the median was 17. Total diazepam equivalence is 70. You see a range from 30 to 120. We don't have a hard upper limit for how much diazepam we give, but again, when things start to get to this upper range, that's when we start having a discussion with the internist to decide, are we keeping, is this appropriate for the AACU, or is this someone that needs to be transferred because of a high diazepam needs and ongoing withdrawal symptoms? And at discharge, the median COS score is 3. So I'll hand it over to Mariangela to give us some other interesting results that we got from our study.
Yeah, awesome. Thank you, Marc. So now let's focus on the changes we observed in alcohol use at 1 and 3 month follow-up based on standard drinks per day. And we found that in the 1 month follow-up, we had 50 patients. And of those, a total of 22 reported abstinence and 23 reported reduced consumption. And also we have 5 who saw no change or experienced an increase in their drinking. And moving on to the 3 month follow-up group with 38 patients, 15 reported abstinence and 20 reported reduction. And we also had 3 patients that reported no change in alcohol use. So in addition to changes in alcohol use, we also explored changes in the domain of well-being. But to begin, let's clarify the concept of well-being that we used or that we applied specifically for this study. So well-being encompassed different aspects, including self-reports of enhanced energy levels, increased motivation for daily activities, successful return to work, improved interpersonal relationships, strengthened social networks, and active participation in psychotherapy. So at the 1 month follow-up, we observed that out of 50 patients, 41 reported improvement in well-being, while 9 showed no change or worsening. And moving on to the 3 month follow-up group with 38 patients, 28 reported improvement in well-being, whereas 10 reported no change or deterioration in this domain. So let's continue with some additional findings. So out of 73 charts that we included, we found that 4 patients, which accounts for 5.5%, required transfer to a higher level of care or needed more care than could be offered in a low acuity setting like the ACU. And the main reason for transfer was due to ongoing elevated SIGWA scores. And from those 4 patients, 3 were not pre-planned, so they were not thoroughly screened, considering that to plan the admission, they need to be highly motivated to change their drinking habits. And one of these patients had multiple comorbidities. However, this reflects that a significant majority, specifically 94.5%, were effectively managed in the AACO, which we already mentioned before is a low acuity setting. And finally, considering that patients were previously followed in the substance use service, we found that 67% were already on anti-craving medications at the time of admission. So before we conclude with the results, let's summarize some key takeaways from our study. So ideal patients for a short stay admission are patients committed or motivated to achieving abstinence or reducing their drinking habit, but they still face challenges such as ongoing daily withdrawal symptoms that make abstinence or reduction difficult without medical support. Patients will be also committed to anti-craving treatment and participate in counseling and follow-up visits as part of their recovery journey. Our findings also suggest that withdrawal management can be supported in a low acuity setting for patients, as Marc already mentioned, without histories of severe withdrawal or seizures, comorbidities related to high risk of benzodiazepine toxicity, or an active psychiatric or neurological disorder. So our study also underscores the positive outcomes associated with elective treatment of withdrawal, showing notable changes at both 1 month and 3-month follow-up, particularly in terms of abstinence and reduced drinking, as well as reporting an improved sense of well-being. Furthermore, this study opens up the possibility to consider elective admissions to other units, including general medical units, short stay, and potentially day units in other hospitals when there is a supporting clinic for follow-up. Okay, so apart from these results, it's also essential to acknowledge certain limitations that could influence these results. So first, it's important to note that patients' self-reporting introduced the potential for recall bias, as patients may not always accurately remember or report their experiences. Additionally, incomplete records and documentation inconsistencies may have impacted the comprehensiveness and accuracy of our analysis. And lastly, it's worth mentioning that the assessment of well-being was not conducted using a standardized tool, and most aspects of well-being assessed were subjective based on charts information. So in conclusion, our study suggests that planned short stay admission to a general internal medicine unit is associated with reduced drinking in motivated patients, increased engagement in community addiction treatment, and an improved sense of well-being. Hospitals equipped with addiction consult services should contemplate elective admissions for highly motivated individuals who struggle with recurrent withdrawal symptoms. However, it's also important to emphasize that further research is required and essential to deepen our understanding and refine our approaches to patient care. And future studies could explore, for example, matched controls, such as individuals from RAM clinics who were heavy drinkers, but were not admitted to the AACU. And additionally, replicating our findings in different low acuity settings could provide valuable insights into the broader applicability of elective admissions in alcohol withdrawal management. Yeah, so that's it. Thank you for listening.
Great, thank you, Marc and Mariangela. Just a follow-up question. So in the chat, Laura asked about whether stable housing was required, and Marc answered no. And I'm just curious as to whether you have enough data, and probably not, I'm guessing, but do you have enough data to tell whether there's a difference in outcomes for the folks with less stable housing or than for other folks who participate in this program?
Yeah, Robin, as you guessed, we don't have enough data to make that conclusion. And just anecdotally knowing, working in the service, it is a smaller proportion that goes through this process that is underhoused. And that probably speaks to our need to improve our access and outreach. But again, also having resources is important to connect patients with resources on discharge. I see, Laura, your follow-up question, do discharges go okay? And that's the biggest challenge. And that's a very good question, because we want to set people up for success. And they go okay when we do that planning beforehand with what is happening next. Where is this patient going? What is different after you leave compared to when you came in? Because if I put you back in the same environment, am I setting you up for success, or what are we doing differently? So I guess those are the things that we try to answer for any patient, but especially important in someone who's underhoused, where it's a bit, resources are a bit more challenging to sort out.
I might add something to that. The thing I would a recommendation might be, since these are people who are highly motivated to stop drinking, is to arrange with a bed-based addiction treatment program, so that you can do their admission to your program as a step in admission to. So like we've talked to Women's College about, if we have a client who's unhoused and who needs to go through that, to refer to you for that on the day before or the day of their admission to our program, so that we can ensure that they're not going back to instability right away. And so that then gives us 3 months to work with them around their housing situation, so that by the time they've got 3 months of abstaining from drinking in, they then are hopefully moving into a more stable environment, right? So I think there's some opportunities in the healthcare system for those of us with community programs to work with you to arrange those things to make it more feasible for those folks, right? Yeah. Of course.
And we actually do that frequently, which is good, but it's just, to your point, it's a matter of how do we connect with even more, because we do that commonly, Gene Tweed, Renaissance, a lot of those places where we try to set up their admission and time this short stay admission right before, so they can go directly from our service to that community-based service. Yeah. But again, it's a matter of like, how do we broaden this outreach? And I think, exactly, your point is very important.
Right. Okay. So I've just, for any other conversation or questions, I've opened it up. So if there are folks who want to ask a question or make a comment, now's a good time. If you could raise your hand, you can unmute yourself. So I'm opening up the floor, and if anybody who would like to ask a question, make a comment, respond to one of the presenters, you're welcome to do so now.
I'm impressed that people have hung in this long. I think everyone did great.
Yeah.
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 Those were 3 great presentations. Really appreciate all of them, and actually the intersections between them and things to think about there.
For sure. For sure. So maybe the answer then is that if nobody has any further questions or comments, that we can have mercy on all of us and say, have a lovely evening, and we will see you tomorrow morning. And thanks again for all of our presenters, and thanks for attending. Thanks, everybody. We'll see you tomorrow.